Hey everybody, Dr. Rob Silverman here, Amazon best-selling author of Inside Out Health, ACA Sports Council Chiropractor year 2015. I am very excited to share some insights with you on SIBO, small intestinal bacteria overgrowth. I can tell you that I gave a presentation this morning on SIBO, and a lot of the doctors had a lot of questions. They have a lot of patients that have prospective signs of SIBO, patients that have confirmed tests of SIBO, and I felt that the information was so warranted that I wanted to share it today on a Friday with you all. SIBO, small intestinal bacterial overgrowth, refers to the idea of excessive bacteria in the small intestine. The small intestine should have a relatively low level of bacteria. There's not much bacteria in the small intestine. There should be much more in what we call the large intestine. The small intestine is the longest section of the digestive tract. It is where nutrients are absorbed into the bloodstream, and unfortunately where a lot of malabsorption of nutrients occurs. One thing I'm going to tell you right off the bat, I would really try to avoid is protein pump inhibitors. They do so, or what they do is suppress stomach acid. SIBO typically represents a breakdown in a protective mechanism. There are several built-in factors that prevent bacteria or overgrowth in the small intestine. So we have these mechanisms. Foremost, the digestive secretions of bile, digestive enzymes, along with the peristaltic contractions that move the food bolus through the small intestine. A lack of enzymes, bile, or other digestive secretions, as well as reduced peristalsis, greatly increases an individual's risk of having bacteria or even candida yeast overgrowth and an intestinal infection, including chronic candida infections of the GI tract. What's interesting, a key barrier to bacterial overgrowth is in the small intestine is this something called the Ileocecal Valve that separates the colon from the small intestine. Much like a door, it's actually a flap, not a valve. It's a mechanical barrier. This mechanical barrier actually doesn't allow bacteria to go from the large intestine back into the small intestine. So we have a multitude of built-in mechanisms to avoid SIBO. So some of the questions that people ask are, why do we have such a high incidence of SIBO? How do you test for it? Well, let's go over some of the stats. Let's go through some of the factoid numbers of SIBO. It has been estimated that 11% of the population has something called irritable bowel syndrome. 60 to 80% of those people in irritable bowel syndrome have SIBO. It's estimated that 550 million people worldwide suffer from SIBO. Actually, 1 in 9 food poisonings lead to irritable bowel syndrome. 60% of people that have a strong diarrhea IBS symptoms could be suffering from what we call post-infectious IBS. So it is more prevalent than we think. One thing I'd like to say about it is when I went to school, chiropractic school 25 years ago, leaky gut was just a conversation piece. It was this new novel idea. And over the duration of time, we found that leaky gut is legitimate. There's a lot of data, and many of the more integrative doctors look at this as a critical element to overall health, avoiding leaky gut, that is. Now, SIBO has really risen in the last 2 to 3 years, if you will, in the functional medicine, functional nutrition market. So I believe that we're going to see that a lot of these people who thought they had leaky gut maybe have it, but also have SIBO. In addition, you're going to find out that a lot of people have SIBO and didn't realize that the SIBO was mimicking some of these leaky gut symptomologies. Some more factoids that everybody needs to know. The small intestine houses about 10,000 bacteria per milliliter of fluid. Conversely, the large intestine houses approximately 1 trillion bacteria per milliliter of fluid. The large intestine, or the colon, has a quantity and a variety of bacteria that's vastly different than the small intestine. The bacteria in the large intestine is there specifically to kill pathogens. Some of the primary functions of that colonial bacteria, in addition, are fermentation of non-digestive carbs, resulting in what we call short-chain fatty acids. These short-chain fatty acids are a great, what we call, postbiotic. That postbiotic is what's left after you go through the process of a pre and a probiotic. Short-chain fatty acids like butyrate are without question a health-promoting moment. Also, some of the primary functions of colonic bacteria are to stimulate epithelial growth and regeneration in the colonic epithelium. So what are some of the symptoms of SIBO? Let's look at the litany. Nausea, bloating, vomiting, diarrhea, malnutrition, weight loss, joint pain, fatigue, acne, eczema, depression, etc. Many of these are, if you will, kind of similar to leaky gut, but SIBO has a distinct symptom pattern. How do you prevent SIBO? I'm a big believer when I look at the gut. I always like to look at the gut in a north to south region. I mean, I do admit that the gut is the epicenter of your health. It's where your macronutrients and your micronutrients are absorbed. 80% of your immune cells are there. Absolutely. Small intestine, all about digestion and things of that nature. However, when you want to prevent SIBO, when you want to look above the small intestine, look at the stomach. And when you look at the stomach, you want to look at the hydrochloric acid amount. Now, in that hydrochloric acid, you also want to see and ask the patient, how does your symptomology respond when you consume protein? Because hydrochloric acid has all these enzymes, these digestive enzymes to break down protein. So if you eat gas and bloating and a little upset from protein, you may be able to attribute it back to a hydrochloric acid issue within the stomach. Within this, getting close to the small intestine, pancreatic enzymes and bile. So pancreatic enzymes are in the pancreas. You really want to look to carbohydrates. If you have a problem with carbohydrates, you may have a problem with the digestive enzymes in the pancreatic region. And of course, bile, which I like to refer to as the emulsifying soap of the body. Typically, you're going to see that bile is a major issue. Bile is going to be an issue if it's not being released from the gallbladder. And when you get below the small intestine, it's more of a mechanical type issue. We're going to talk about them in a little bit more detail. The ileocecal valve, which we said is the doorway between the small intestine and the large intestine. It's a doorway because if it's open or it doesn't close, it should move. It should be fluid. If it's stuck in any one direction, you have a higher incidence of small intestine. So I see somebody say, could you explain that a little more? Sure. So here's your small, and here's your large intestine, and here is your doorway. So your doorway should open and close. Obviously, if it stays open too long or it stays closed too long, a lot of the food bolus from the small to large intestine won't get through. It'll house back in the small intestine. You'll have small intestinal bacterial overgrowth. If it's open too much, you get a kickback from the large to the small intestine. The migrating motor complex. The migrating motor complex allows the peristaltic or the continuation of peristalsis, peristaltic wave-like electric contractions from your stomach to your small intestine into your large intestine. In a perfectly functioning individual, you have 9 to 11 peristaltic contractions per day. In SIBO, you have approximately 3. So you're not moving that food bolus quite as much. That poses an absolute issue. SIBO also has a tremendously high reoccurrence rate. It's about 12.6% at 3 months, 27.5% at 6 months, and almost 44% at 9 months. Common SIBO relapse timeframes are about 2.5 months unless underlying causes are treated. So you're not just treating SIBO, but why do you have SIBO? And that always gets, and that's the flashpoint in functional medicine. That flashpoint is root cause resolution. Why do we have that condition? Don't treat the symptom, treat the system. Don't put out the smoke, find out where the fire is. So SIBO is very interesting in that patients with SIBO have a tendency to have a high altered secretory IgA value. This secretory IgA is usually an antibody that's released at a mucous membrane, so obviously you're going to get that at a high amount, or it can be very prominent in the gut region. Altered secretory IgA values demonstrate that SIBO directly alters immune activity in the gut. So it's a great marker to look at. So what tests are going? I'm going to have a big shout out to my buddy, Dr. Lauren Marks. We're going to get him on here. He already promised me he'll do some blood markers with me in the next couple of days. I know he's a great SIBO expert, so he always is giving me, without question, a great edification on the different tests that you can look at with SIBO. We're up to this part. The future holds these breath tests, many of which come from Mark Pimentel. Here you have hydrogen and methane breath test, a common method of assessing SIBO. Hydrogen has a greater association with diarrhea. Methane, almost an exclusive association with constipation. Once again, I really want to go into a little more detail with the migrating motor complex. So just to reiterate, it functions to move contents from the stomach and the small intestine to the large intestine. It's stimulated by fasting and inhibited by feeding. So yes, the migrating motor complex functions much more efficiently when somebody has a time-restrictive eating or intermittent fasting mode to their diet and their lifestyle. The vagus nerve is a critical element for proper migrating motor complex function. So this migrating motor complex is fascinating in that the vagus nerve communicates with it. So here's a factoid. Many patients who have a concussion also get SIBO, because when you have a concussion, you decrease the tone of the vagus nerve, leading you down to a slowness of the migrating motor complex. Migrating motor complex, interestingly enough, has a hormone called molten, which is released by cells in the jejunum and duodenum, the large and small intestines, which is involved in your interdigestive fasting state for migrating contractions. It's involved in cleaning out the gut in preparation for the next meal. It's the housekeeper of the gut. It contracts gallbladder also. So interesting, erythromycin acts as a molten antagonist, agonist. So the migrating motor complex, there's 4 actual phases. Phase 1 has no motility contractions. It's about 55% of the total gastric cycle. Phase 2 is regular or irregular low amplitude contractions that do not propel contents. 41% of gastric cycle GI rumbling may be associated. Phase 3 is the activity phase. It actually contributes to only 4% of the total gastric phase. It acts to sweep the lumal contents, stomach to duodenum to small intestine into the colon. It's actually a secretory component. The absence of phase 3 is what is associated with small intestinal bacterial overgrowth. So you have specific reasons or underlying causes, if you will, of SIBO. Let's go through a few of them. Bacteria, or something like LPS, or most predominantly cytolethal distending toxin. I said it before. You can get concussion, chronic infections, vagus nerve damage, mold, microtoxins. Typically digestion, impaired digestion is going to be a big component, like decreased bile flow, stomach acid, and pancreatic acids also. Issues in what I call issues above the intestines or in the intestinal area, where you're getting scar tissue from a C-section, some sort of incision from the ab. That scar tissue holds down and damages the migrating motor complex and or the ileocecal valve dysfunction. And a few others, of course, are always prescriptions like frequent antibiotics and protein pump inhibitors, and opiates are also a great cause of SIBO. So a lot of people want to know, what about a SIBO protocol? So I'm going to share one that I use in my office that I found to be quite effective. Phase 1, the first 30 days, approximately. You want to add bile salts and ox bile with each meal. Bile salts and ox bile help the body break down fats in the diet, support optimum fat digestion and healthy liver and gallbladder function. The small intestine typically is quite high in bile acids. These do in fact decrease bacterial growth. This does not apply to our good bacteria though, as the good bacteria are resistant to antimicrobial effects of bile. Bile also helps to regulate or initiate the migrating motor complex, the process that sweeps the intestines clean in between meals. It is the antimicrobial properties of bile that help to keep the terrain of the small intestine clean and prevent bacteria from the colon from colonizing the small intestine. You want to add aromatic oils like oregano oil. They take care of, in mints, they take care of a lot of the upper respiratory or upper colon's bad bacteria, so it kills bad bugs. It's known to cleanse the bowel of bacteria, viruses, yeast, and parasites. Berberine. Berberine's used, it's a beautiful herb. Berberine's used more for some of those very complicated patients, the train wreck patients. Berberine in the bowel, dysbiosis, cleans GI tract, killing more bacteria, viruses, yeast, and parasites. And I do take a probiotic at that point, and I do recommend a probiotic at that point. I do. One of the ones that I recommend, the one that you can hang your hat on, if you will, would be Saccharomyces boulardii. Saccharomyces boulardii is a yeast that performs like a probiotic, so it has none of the adverse effects. Virtually all the formulations I do, or all the protocols, if you will, that I give, always has a Saccharomyces boulardii in it. There was a study in 2017 that spoke about probiotics for treating and preventing SIBO. They found out that a probiotic supplementation could effectively decontaminate SIBO. It actually helped relieve abdominal pain. The pooled analysis found probiotics were remarkably effective for the treatment of Sibo. Why do I mention that? Because there's been a lot of rhetoric back and forth about whether you should add a probiotic or not. And the answer is a resounding, you can use a probiotic during Sibo protocol. Good study in 2019 on Aspergillosis backing up what I said about improving outcomes and GI outcomes in Sibo. Continuing with phase 1, zinc carnosine. And you always want to take zinc carnosine on an empty stomach. Zinc carnosine has a mucosal protective property. Zinc carnosine lessens the exercise-induced gut permeability, which is increased epithelial resistance and enhanced tight junction formation and stabilization. The key to zinc carnosine, which has dozens of scientific papers over years and years of literature, it's known to enhance the repair of stomach lining. You want to take it on an empty stomach. Now let's get to the diet. Most people adhere to what we call, or have read to adhere to, a FODMAP diet. Now, I have to say that for me at this juncture, I am not a big proponent of the FODMAP. And the reason is I found patient compliance to be poor. And that's not okay. That's almost like zero. Now, there's a lot of good ones out there and broken down, but I'm not a big proponent of the FODMAP diet. However, I do like the ketogenic diet. But before I go any further, let me explain to you what the FODMAP diet is. It's an acronym for fermentable oligosaccharides like fructans, disaccharides, lactose, monosaccharides, fructose, and polyols, sugar alcohols. My preference is the ketogenic diet. The ketogenic diet, 75% fat, 20% protein, 5% carbohydrates. I'm a big proponent of keeping carbs out of the gut, keeping carbs out between the gut to brain axis. You can have some carbs, but let's avoid the carbs that are made by men. Let's avoid the carbs that are starchy carbs, very high in the glycemic index. So now we're continuing with phase 2, the next 30 days, let's say. So month 1, month 2. Betaine, HCl, and pepsin, great stomach acid. Titrate per meal. You want to titrate up. We found out through data studying an insufficient output of digestive enzymes from the pancreas, as we get into the pancreas, is associated with many symptoms associated with Sibo and may represent a key underlying factor in many cases. Digestive enzymes are also likely host defense mechanism within the gut that can once again prevent the formation of biofilm. These pancreatic enzymes, amylase, lipase, protease, catalase, they're great. You should take them with every meal. And of course, always continue with the bile salts, ox bile, within each meal. At this point now, you want to add to the Saccharomyces boulardii. I would recommend a more well-rounded, dairy-free probiotic that helps gut flora, supports digestion, something that I use an awful amount of time, often in a liquid, and it's probably my favorite probiotic. It's a liquid one made by a good friend of mine, Dr. Jared Work, and it's called Flourish. You also want to add a nutritional support powder because you want to be able to heal some of the damaged gut lining, which typically provides a strategic macro and micronutrient support for those compromised with gut function. And you always want to stick on the diet. You want to have a plethora of different nutrients to help regenerate that gut lining. Of course, with the combination of the food and the supplement, a lot of people say to me in this, when I give a protocol, especially a nutritional protocol, why do you add supplements? Well, supplemental to lifestyle, supplemental to food. Food is part of a lifestyle. Supplemental in general. A depleted cell cannot be repleted with food alone in a very quick, efficacious manner. So you need all of it. You're going to need a lot of kale. I always use that as an example. You're going to need a lot of kale. You're going to need boatloads of kale to get the nutrients up since you're so depleted. So the supplements will rise you and get you up. I used an example this morning about that. Many people that we talk to own a house. And many people who own a house, not all, but many, have a mortgage. Most people have a mortgage because they don't have enough money to put down for the house. So you put your down payment and then you pay your mortgage off. The supplements are the mortgage. So it would give you all that you need to get the threshold, if you will. If you wanted ongoing care, which I believe a lot of people should. You should always take care of your gut. What have you done for your guts lately? Do you have the guts to be healthy? Ongoing care. My suggestion, ongoing care for health, not to have a relapse of SIBO, would include taking bile salts and ox bile, possibly with each meal. Continuing with the nutritional powder to support intestinal lining and GI health. That would be great for overall health. I would recommend you doing it in general, and always continue with a good probiotic like an Asparagine, L-Plantarum, and a Flourish. One study that I really wanted to share with you, again, to really hammer home and allow this one point to truly resonate for any of the proverbial naysayers. The effects of 4 probiotics on symptoms of patients with IBS and association with SIBO from a 2018 study. The 4 probiotics are Asparagine, B-lactis, Lactobacillus acidophilus, and L-Plantarum. The conclusion was, stand by, here it is, 71.3% improvement in the symptoms of IBS in patients with SIBO versus 10.6% without SIBO. So, if you had IBS and you took a probiotic, you improved over 10%. Massive. However, if you had IBS and SIBO, it was 71.3%. So whoever has said no probiotic with SIBO really isn't following the data right now. Some verbal conclusion. The benefit of probiotics is greater among patients with pro-inflammatory cytokine pattern in the duodenal fluid. The first study, this one I'm reiterating, is the first study to demonstrate superior clinical efficacy of probiotics in patients with IBS and SIBO. Factors which help you protect against SIBO. Please make note. Pancreatic and biliary secretions. Gastric acid. Keeping your mucosal immune system and epithelial lining intact. And of course, your migrating motor complex and your ileocecal valve. So I hope you guys found that valuable. I see some questions, so I'm going to get right into the questions. I see somebody asking about a spasm of the colon. Spasm of the colon is usually spastic IBS or spastic IBD. It's vastly different than SIBO. That doesn't mean you don't have SIBO. I'm always a big proponent of taking a good look and always having somebody fill out a form. If anybody's interested, I have what we call a gut assessment form. You can give us a call or email in to info@drrobertsilverman.com. We'll send you out a gut assessment form. Be very happy to do that. It's always my pleasure. Anybody have any questions, feel free to ask, share, comment. SIBO is a huge topic. We'll be doing more in the future. I appreciate all your time. Thanks for listening. Dr. Rob Silverman, always yours.